Good day, everyone. Welcome to today's APSC Consensus Statement session. My name is Jack Tan, the immediate past president for the APSC, your chair for today. My co-chairperson, we're very privileged to have Professor Koji Maemura from the Department of Cardiovascular Medicine, Nagasaki University, Graduate School of Biomedical Sciences. We have two panelists today, respectively from Bangladesh, Dr. Fazila Malik from the National Heart Foundation Hospital Research Institute, as well as Dr. Arintaya from Thailand, Faculty of Medicine from Chiang Mai University. We have four speakers today to narrate to us the four consensus statements, respectively from Australia, Liverpool Hospital, we have Dr. Sidney Lo, Dr. Ronald Chi-Hang Lee from the National University of Singapore, as well as Dr. Yoo Yeo, likewise from the National University Heart Center. And lastly, but not least, Professor Khung Keong Yeo from the National Heart Center, the current chair of the APSC SAB. Without further ado, I'd like to welcome Dr. Sidney Lo to talk about the first consensus statement on CAD, PAD, and the bleeding risk assessment. Sidney, please.
Thank you very much, Jack, and thank you. It's my honor to be in this session of work that was amazingly done by APSC in recent years. And so as you know, these are my conflicts. Atherosclerosis is a systemic vascular issue. And of course, we know that it can happen in many vascular beds. In the REACH registry, as you can see, if you have a combination of coronary artery disease, cerebral vascular disease, and PAD, there's an extreme risk for things like stroke and adverse cardiac events. And it also, CAD-PAD remains a factor even when there's more than one vascular bed. Now, despite that residual risk after in this phase of chronic coronary syndrome, we can see that additional comorbidities such as renal failure, diabetes, heart failure, and polyvascular disease increase significantly that residual risk. And therefore, you can double that risk despite that initial issue. We also know that despite this risk and despite standard of care therapy, and this is quite old data now, anti-platelet trial collaboration, the Capri trial looking at different vascular beds, Charisma and Pegasus using ticagrelor, we can see that there's still a residual risk despite using new and more potent therapies. It's always a difficulty considering bleeding because that's an effect of therapy and your native ischemic risk, and many factors cross between the two. And we always find ourselves between a rock and a hard place. So in the Asia Pacific region, characteristics of CCS may be unique. Heterogeneous approaches because of differences in access and resources, and there's a low number of Asian Pacific patients recruited into large pivotal trials. And therefore, international guidelines may not be so routinely applied to us in the Asia Pacific region. So the APSC has developed consensus recommendations to summarize current evidence and offer some help to clinicians in the region. Now, these are some of the consensus documents to date, and we're going to focus today on the high-risk chronic coronary syndrome patients. And this is the way we establish consensus using online polling, consensus building, but a cutoff for consensus was around 80% agreement or neutral, and grading of the evidence that was attached to. This was published in the European Cardiac Review. Notice that we say that chronic coronary angiogram or CT coronary angiogram or other imaging techniques may be used where available to confirm that diagnosis of chronic coronary syndrome diagnosis, to estimate the extent of stress-induced ischemia, and evaluate burden of disease. However, concomitant patient risk factors should be appropriately managed according to local healthcare guidelines because we're so different even amongst countries in the Asia-Pacific region. Acute coronary syndromes or those who have percutaneous coronary intervention transit to this phase of chronic coronary syndrome at the completion of their prescribed period of dual antiplatelet agents. For ACS patients, this is about 12 months on average and commonly, and whereas PCI patients may be 1 to 3 to 6 months, depending on how long you want to do DAP for after a stent is placed. East Asians, of course, have always long known to have lower thrombotic risk but higher bleeding risk, especially for intracranial hemorrhage and gastrointestinal bleeding. Now, we sometimes can mitigate, and there's some actual recommendation in the consensus guidelines that at the point of a stent procedure, which can determine the transit into the CCS phase, image-guided PCI, OCT or IVUS may be useful because it may allow you with confidence to taper or shorten the DAPT period. But the evidence of level of evidence is considered low, but we have general agreement. Drug-eluting stents were preferred, and we have agreement on that. And that's very similar to European guidelines, where every angioplasty should preferentially be DES. Balancing the risk of thrombosis and bleeding when you select antithrombosis therapy, the statement 5 suggested that bleeding and thrombotic risk of a patient should be assessed before determining which one to use. And that's a generally great agreement. And sex, gender alone should not be considered when assessing the bleeding and thrombotic risk. So we come up with a way of easily in the clinic organizing this kind of assessment. So it's called ABO, using the age, bleeding, and organ dysfunction risk. And generalized, you can see that there's a great consensus there. Advanced age alone is insufficient to confer excessive bleeding risk in CCS patients in Asia Pacific. And also hemoglobin levels less than 9 grams per deciliter should be considered as an indication for anemia in patients with assessing bleeding risk. Now let's look at this little diagram because it's easy to use. Now we know that age is a prevalent risk factor in most guidelines, and ARC-HBR, Academic Research Consortium, high bleeding risk scores have incorporated, and they've only suggested age as a minor criterion because age alone itself may not be so influenced in terms of bleeding risk. And so you need to be frail only over age 75 with an additional risk factor to make it higher risk. Even advanced age, say 85, you need additional risk factor to cross the line to be high bleeding risk, life expectancy less than 1 year. In terms of bleeding, spontaneous ICH, recurrent GI bleeding, or hemoglobin less than 9 grams per deciliter. In terms of that's because in Asia Pacific, maybe the generic level of hemoglobin may be lower due to the presence of things such as thalassemia. And so therefore we dialed that a bit lower than most of the previous published reports. Organ failure, liver cirrhosis, end-stage renal failure requiring dialysis, bone marrow failure, particularly thrombocytopenia with platelet counts less than 50,000, and stroke in the last 6 months would cross the line. And it's a bit binary, and so we thought it'd make it quite easy in a sense. In terms of thrombotic risk, we say that high thrombotic risk, we have a CVD algorithm, so it's consisting of coronary, vascular, and disease status. So a prior coronary event, high-risk coronary artery anatomy, documented multi-vessel coronary artery disease for C, and for V, vascular factors, particularly peripheral artery disease, cerebral vascular disease, and for disease, other disease in terms of diabetes on treatment, renal disease with eGFR less than 60 mils per minute, micro and macroalbuminuria, and heart failure due to coronary artery disease. Now, the selection of single antiplatelet therapy, either aspirin or clopidogrel rather than DAPT, is recommended for Asian CCS patients with low ischemic risk or excessive high bleeding risk. And the recommendation is fairly high consensus. Extended DAPT is recommended for Asian CCS patients without high bleeding risk features and who have undergone either PCI with complex stent features. There's also a high level of agreement for that. Dual pathway inhibition with aspirin and low-dose rivaroxaban is recommended for Asian CCS patients with high thrombotic risk and without high bleeding risk. And those who have residual multivessel coronary artery disease, polyvascular bed disease, prior stroke, or prior MI. Now, this is a reasonably good diagram. We should go through it a little bit. Transiting from DAPT, and remember, for just a stable patient that had a PCI, it could be anywhere between 1 and 6 months. But for ACS patients, generally speaking, generically, DAPT is recommended for 12 months. And therefore, transiting to CCS phase, maybe at 12 months for most ACS patients. We assess their CVD thrombotic risk factors. If you have one dichotomously, then we go and look at their bleeding risk factors. If you have high bleeding risk with ABO risk factors, excessive bleeding risk, then single antiplatelet is recommended. In this case, aspirin or clopidogrel. And if you have no excessive bleeding risk, then it's either DAPT if you have complex PCI, extended DAPT that is, or DPI if you have residual multivessel coronary disease, polyvascular disease, or prior stroke or prior MI. Notice that DAPT could be a combination of either aspirin and clopidogrel, or ticagrelor or prasugrel. And DPI, of course, is aspirin low-dose rivaroxaban twice a day, 2.5 milligrams, as per the COMPASS study. If you had no severe thrombotic risk factors with CVD as an assessment, and you were low risk of ABO risk factor, then single antiplatelet is recommended. That's usually aspirin or clopidogrel. There were other consensus statements, and we'll take a couple from special populations from the P2Y12 receptor antagonist statement, and largely relates to renal failure. So I guess if you had renal dysfunction, and this is eGFR 15 to less than 60, perform early revascularization or catheterization, ACS, 12 months of DAPT, balancing risk of ischemia versus bleeding, single antiplatelets or aspirin clopidogrel if with excessive bleeding, then of course DAPT or DPI may be used to transit to CCS. In stage 5, end-stage kidney disease, less than 15 mils per minute, early revascularization and cardiovascular catheterization, shortened DAPT for high bleeding risk, consider single antiplatelets after 3 months in these dialysis type of patients, and of well-tolerated DAPT post-PCI. So in diabetics, which also is a risk factor, we notice that if you have type 2 diabetes with established cardiovascular disease, then of course antiplatelets should be recommended for secondary prevention. For diabetes patients with an MI or undergoing PCI, extended DAPT regime may be considered. And for diabetic patients with complex PCI and high bleeding risk, ticagrelor monotherapy may be considered after 3 months of DAPT. It's very similar to the Twilight study. Multivessel coronary artery disease, extended DAPT for more than 12 months can be considered for patients with multivessel CAD post-revascularization, PCI or CABG, and patients with multivessel CAD not amenable to revascularization to receive antiplatelet therapy. And after bleeding, so which may occur, the decision to discontinue antiplatelet therapy should be based on assessment of the severity of bleeding and the proximity of the bleeding event to the index bleeding event or ischemic event of PCI. As much as possible, patients with bleeding within 1 month of index event should continue antiplatelet therapy once stabilized to minimize ischemic risk. And patients with bleeding who require a step down of antiplatelet therapy may consider switching to less potent antiplatelets, reduction in the antiplatelet dose, as in parts of Asia, or the use of single antiplatelet agents. So I'll take some questions. Thank you very much for your attention.
Thank you, Sidney. So well presented. Thank you very much for doing that. Now I'd like to welcome comments from our panelists. Dr. Arintaya first, for your comments for this lecture.
Thank you, Professor Lo, for your comprehensive review of the guidelines regarding coronary artery disease, peripheral artery disease, and anti-thrombotic. I'll have some comments and questions on the consensus regarding the bleeding event and thrombotic risk. As you mentioned, that East Asian has a lower thrombotic risk with a higher bleeding risk. Just want to ask about your opinion or recommendation about the duration of DAPT. Would it be possible to use shorter duration as a default and consider the high thrombotic risk to extend the DAPT duration rather than 6 months after spending?
So notice that the recommendation here is based on what you would do clinically. So when you enter CCS, it's like a largely clinician determined way. So if you were stable-ish without an ACS event, had a stent, then you can determine how long you would do DAPT for, and your comfort level for most people, based on things like Twilight, would suggest 3 months would be a reasonable time frame. If you personally felt that after PCI, and this is where that recommendation for imaging comes in, I think the comfort level for most interventional cardiologists to recommend shortening the DAPT may be improved. Now, we saw this studies like STOP-DAPT2 and STOP-DAPT1 in Japan, because they do a lot of imaging, the confidence at which they can reduce down to 1 month is increased. And therefore, we had a recommendation to say, let's just recommend this and see if people would actually then able to shorten it even further, particularly for stable patients with stents. And so that we did not make a recommended duration, because if you went from that, as you know, for ACS per se, it's going to be 12 months for most people. If you consider high bleeding risk, then you can dial down, particularly down to, like we had in the other bit of guidelines with people needing atrial fibrillation management, as low as 1 month thereabouts. Now, I know that most people may even recommend that they just go to dual therapy very quickly within a few days after the ACS. And that would, I think imaging would help you. So unfortunately, there's no one rule. has been individualized.
Thank you.
Thanks, Sidney and Arinata. Fazila, do you have a last comment?
Yeah, that was a great presentation, Sidney. Really enjoyed it. But the fact remains that, this region, the population is so heterogeneous and so diverse that, making a consensus treatment can be quite difficult. Now, the imaging thing really makes a lot of sense, but how do we deal with it in countries where they cannot afford to have imaging on a regular basis? Like in Japan, imaging is done almost routinely, whereas in Bangladesh, we would do it once, in a blue moon. So how do we reconcile that?
Yes, look, I think that we do recognize there are huge regional disparities in terms of ability to afford imaging. But I think moving forwards, having this document is helpful in pushing regulatory authorities and governments to try to fund some of this. Obviously, we can't expect 100% of patients being stented having imaging, and it's very much to ask in some jurisdictions. But having these documents and continuing evidence will push regulatory authorities and governments to help fund it. And of course, we're working on this. And as you know, with the recent meta-analysis of ultimate follow-up at 3 years of trial, IVXP at 5 years, there is now a demonstrable cardiovascular mortality in 2 randomized trials. And we think the guidelines internationally may change soon on this. And so maybe that's useful as well. I mean, funding is always very complicated. There's more jurisdictional approach in many countries. But yes, if you can do it, it makes you much more comfortable.
Absolutely.
Thank you, Sidney. Congratulations for being the senior lead author for this paper. And Prof. Koji, should we move on to the second?
Yes, okay. Then let's move on to the next speaker. Speaker 2 is Dr. Ronald Chi-Hang Lee from National University of Singapore. The title is Assessment of Sleep Apnea in Asia. Dr. Lee, please.
Thank you, Chairman. Can I'll just please share my pre-recorded presentation. Having me here today for this very important section. My name is Ronald Lee. I am from the National University of Singapore. And the title of my presentation today is Assessment of Sleep Apnea in Asia. And I have no conflict of interest to declare pertaining to this presentation. Obstructive sleep apnea is a chronic disease characterized by recurring collapse of the upper airway during sleep. And this recurring collapse leads to a cascade of reactions, which include hypoxemia, sympathetic activation, endothelial dysfunction, and also platelet activation. This video is a sleep endoscopy performed at my hospital. It illustrates a very congested upper airway in a patient with obstructive sleep apnea. And some of you could probably hear the audible snoring. During complete collapse, as seen here, there is profound hypoxemia, with oxygen saturation dropped to as low as 60 to 70%, imposing a significant stress to the cardiovascular system. In the past 2 decades, enormous amount of high-quality scientific data have highlighted that obstructive sleep apnea is a novel cardiovascular risk factor that need to be screened and treated. These are being summarized in these 2 American Heart Association scientific statements, which was published around 6 months ago on adults and pediatric population respectively. These highlight the importance of untreated obstructive sleep apnea in the development of cardiovascular disease. This is a very important publication that was released 2 years ago that reported estimation of the global prevalence and burden of obstructive sleep apnea. For the first time, this article reported that in the world, there's almost 1 billion people affected by at least mild degree of obstructive sleep apnea. And out of these 1 billion people, approximately 50% of them have at least moderate to severe form of obstructive sleep apnea. And some of the data has actually come from Asia, and you can see from here, including Malaysia, Japan, and South Korea. This slide shows the top 10 countries with the most number of patients affected by obstructive sleep apnea. As you can see, out of the top 10 countries, 4 are actually from Asia, namely Japan, China, India, and Pakistan. Japan alone, at least 9 million people are being affected by at least moderate form of obstructive sleep apnea. In China, at least 66 million people are affected by at least moderate form of obstructive sleep apnea. India, we have 29 million. In Pakistan, we have 17 million. And that slightly illustrates the relevance in importance of screening for and treating obstructive sleep apnea in Asia. At least partly contributed by obesity epidemic, recent population studies have found a much higher prevalence of sleep apnea compared with the older studies. In the upper half of the slide is a recent population study reported from Switzerland, where the investigator reported that 23% of the women and up to 50% of the men have at least moderate to severe form of obstructive sleep apnea. And around the same time, our group in Singapore also reported similar findings in Singapore. We found that 30% of the Singapore general population have sleep apnea. Among the three ethnic groups in Singapore, we also observed an ethnic variation, with Chinese and Malay more likely to develop obstructive sleep apnea than Indian people. Most importantly, 91% of the people found to have obstructive sleep apnea after a screening sleep study were not aware of the condition. This highlights the importance of public education and sleep study screening in promoting the importance of sleep hygiene and sleep apnea in the general population. In this regard, health screening is very popular in Singapore. This is based on the belief that detection and treatment of silent heart disease might prevent future catastrophic coronary events. In a published study, we investigate the receptiveness of the individual who joined our cardiovascular health screening towards having an additional sleep study incorporated into the package. Out of the nearly 700 individuals approached, 60% of them had agreed for an overnight sleep study to look for sleep apnea, and the preference of sleep apnea detected was found to be 38%. We further analyzed the data of the 358 individuals who underwent a successful sleep study by comparing the sleep apnea severity with the various cardiovascular risk markers. And we found a positive correlation between apnea-hypopnea index and the serum level of high-sensitivity C-reactive protein and triglyceride levels, and a negative correlation with exercise capacity. These association and correlations persist after adjusting for confounding variables. And our findings suggest that perhaps individuals with obstructive sleep apnea may have an increased risk of developing future cardiovascular events, including ischemic heart disease. With regard to ischemic heart disease, we reported this study that used the IFAS technology. We measured the target vessel plaque volume in patients with without obstructive sleep apnea who underwent a clinically indicated coronary angiography. We found that the patients with obstructive sleep apnea have much higher coronary plaque burden than those without sleep apnea. After adjusting for the effect of age, body mass index, hypertension, smoking, diabetes, and hyperlipidemia, obstructive sleep apnea remained an independent and important predictor of total arterial volume. Although this association study could not prove causal relationship, at least it suggests that obstructive sleep apnea could be an important factor contributing to the development of coronary atherosclerosis. Percutaneous coronary intervention, PCI, is a very important modality of therapy for the patient with ischemic heart disease, and PCI is performed widely. And therefore, we find that it's important to look at the effect of obstructive sleep apnea in cardiovascular outcomes in patients who underwent a percutaneous coronary intervention. In this particular sleep and stent study, we recruited over 1,300 patients who underwent a successful PCI procedure, and this patient underwent an overnight sleep study before hospital discharge. We find that 45% of these patients indeed have obstructive sleep apnea, and these patients were then divided into two groups OSA group as represented by the red line, and the non-OSA group as represented by the blue line. You can see that after 2 to 3 years after the PCI procedure, patients in the OSA group have a higher incidence of major adverse cardiovascular event as compared with the patient in the non-OSA group. The 3 years estimated event rate was 18.9% in the OSA group versus 14% in the non-OSA group, with the p-value of 0.001 and the absolute difference of 5 percentage points. It's important to notice that the incidence of high incidence of adverse event in the OSA group was contributed by all 4 components of the primary endpoint, namely the cardiovascular mortality, non-fatal MI, non-fatal stroke, and unplanned revascularization. While the sleep and stand study was not powered for individual components of its primary endpoint, it's important to take note that the incidence of cardiovascular mortality was significantly higher in the OSA group, 2.7% versus 1.1% in the non-OSA group. In the Cox regression analysis, OSA predicted incidence of adverse cardiovascular event with an unadjusted hazard ratio of 1.72. The statistically significant association was retained after adjusting for the effect of age, sex, ethnicity, body mass index, hypertension, and diabetes, with an adjusted hazard ratio of 1.57. Apart from PCI, coronary artery bypass surgery, or CABG, is another important revascularization therapy for patients in general with a more severe and extensive form of coronary heart disease, in particular patients with diabetes and heart failure. And therefore, we conduct a parallel study to look at the effect of sleep apnea on cardiovascular outcomes in patients who underwent a successful coronary artery bypass surgery. In this particular study, we have recruited over 1,000 participants who underwent a successful coronary artery bypass surgery and they underwent a sleep study screening. They found that 51% of the patients did have obstructive sleep apnea, as represented by the red line here, and 49% without obstructive sleep apnea, as represented by the blue line here. Once again, you can see that after 2 to 3 years after the in-depth bypass surgery, patients in the OSA group have a higher incidence of major adverse cardiovascular event than the non-OSA group, which is represented by the blue line. The 2-year estimated event rate was 14.7% versus 7.8%, with an absolute difference of 7 percentage points and a p-value of 0.003. It's also interesting to notice that apart from the higher incidence of major adverse cardiovascular event, patients with obstructive sleep apnea also have a higher risk of all-cause mortality after bypass surgery, higher risk of cardiovascular mortality, higher risk of sudden cardiac death or resuscitated cardiac arrest, and also higher incidence of having heart failure hospitalization. Cox regression analysis shows that sleep apnea predicted incidence of major adverse cardiovascular event in an unadjusted Cox regression analysis, with hazard ratio of 1.69, and the association remained statistically significant with an adjusted hazard ratio of 1.57 after adjusting for the effect of age, sex, body mass index, left ventricular function, diabetes, hypertension, chronic kidney disease, and also excessive daytime sleepiness. Unlike hypertension and diabetes mellitus, in which the diagnosis can be achieved by simple blood pressure measurement and fasting blood sugar test, the diagnosis of obstructive sleep apnea relies on overnight sleep studies, which are frequently expensive, labor-intensive, and also highly limited in availability, particularly in Asian-Pacific countries. As a result, screening questionnaires have played a very important role in identifying patients who are more likely to have obstructive sleep apnea. Today, the Stop Bank questionnaire, the Epworth Sleepiness Scale, and Berlin questionnaires are the 3 widely used questionnaires in clinical practice. These questionnaires make use of the patient's characteristics and OSA symptoms to select individuals who are at a higher risk of having obstructive sleep apnea. And patients having a high risk of having obstructive sleep apnea would then be subject to proper sleep studies. According to the American Academy of Sleep Medicine, AASM, sleep studies are categorized into 4 types: type 1, type 2, type 3, and type 4. The level of sophistication and accuracy decrease from type 1 to type 4. Type 1 is a polysomnography, or PSG in short, is conducted in a sleep laboratory, and the process is monitored by a sleep technologist throughout the night. This is the gold standard for the diagnosis of obstructive sleep apnea and other forms of sleep disorder breathing. Type 2 sleep study is similar to type 1, except that there's no sleep technologist monitoring the process. Type 3 have fewer signals, and importantly, there's no EEG signal, okay? And therefore, it decreases the accuracy and reliability of the sleep study. But the advantage of the type 3 study is that it could be performed easily at the patient's home. Type 4 usually comprises a simple pulse oximetry, and hence the accuracy is not considered satisfactory and is not widely used. Given the limited published clinical data on the management of obstructive sleep apnea in patients with cardiovascular disease in Asia-Pacific area, the Asia-Pacific Society of Cardiology, led by Professor Jack Tan, has developed a consensus recommendation to guide general cardiologists, internal medicine specialists, and sleep practitioners in the Asia-Pacific region on the diagnosis and treatment of obstructive sleep apnea in patients with cardiovascular disease. These recommendations are intended to improve screening, early diagnosis, treatment, and management throughout the Asia-Pacific area. First of all, patients with resistant hypertension, atrial fibrillation requiring cardioversion or ablation, or unexplained pulmonary hypertension have an exceptionally high risk of severe cardiovascular adverse event. And therefore, for this patient, treatment for OSA has been shown to confer benefit. And therefore, the panel worked in favor of early referral to a sleep specialist for pulm evaluation and treatment in such individuals. If the patient do not have this high risk feature, then we will base on the symptom or questionnaire result to determine whether further sleep study is required. Okay, the patient are deemed to have a high risk of obstructive sleep apnea, then we will see whether this patient has underlying cardiopulmonary diseases, including heart failure, including congenital heart disease, or complicated valvular disease. In case this patient have this cardiopulmonary comorbidity, it's considered that they have a high likelihood of having complex sleep apnea or central sleep apnea, and therefore, level 1 polysomnography being the gold standard is generally recommended as the modality of sleep study. In patient without this mentioned cardiopulmonary comorbidity, then either level 1 PSG or home sleep apnea testing, which are level 2 and level 4 studies, are considered reasonable. After the PSG report is out, we have to certainly review the report. If patients have a coexisting sleep disorder, for example, REM behavioral disorder breathing, it would be better to refer to a sleep specialist for specialist management. However, if the patient only have obstructive sleep apnea, that is possible for cardiologists with relevant expertise and training to manage the patient. For patients with mild form of obstructive sleep apnea, with apnea-hypopnea index less than 5 per hour, in general, conservative management, including weight reduction, positional therapy, are recommended. If the patient does not respond to this conservative management, then treatment with CPAP or the advancement device, which is dental device or mouth guard, or surgery may be considered as a second-line therapy. However, for patients with found to have a moderate to severe form of obstructive sleep apnea, in general, we will treat the patient with CPAP therapy, being the first line recommended treatment. However, based on our experience, approximately 30% of the patients either do not prefer to have CPAP or find CPAP intolerable. If that's the case, the second line treatment, including the advancement device, once again, is a mouth guard, a dental device, or surgical therapy for patients with suitable anatomy are the recommended treatments. Finally, patients who are found to have predominantly central sleep apnea or mixed form of sleep disorder breathing, due to the complexity of the issue, is in general better to recommend to the regional sleep specialist for management is being recommended. Thank you very much for your attention. Thank you. Okay, thank you.
Thanks, Ronald. Now I'd like to welcome a comment from Dr. Fazila. Do you think this is appropriate for Bangladesh?
Well, I mean, the studies showed that that was a great presentation, by the way, really enjoyed it, and it was very insightful. And you showed by studies that it does impact results of the work we do, PCI, CABG. When a patient has an obstructive sleep apnea, obviously his outcome is much worse, as you showed, and even the atherosclerotic burden. So of course it's relevant. The fact is, I feel that we need to make our patients more aware of these factors. But I mean, most patients who have a PCI, that they know that they should quit smoking, and we talk to them about that. We tell them that they need to control their diabetes, and we make a point of, checking their diabetes and the blood pressure. But how many of us do we sit down and talk about obstructive sleep apnea for them? Most of our patients, like the spouse comes and says, my husband snores. And then we say, oh, does he? And then we sort of start looking into it. But I think physicians also need to be aware of this, and patients also need to be aware that this can be a life-threatening problem. I think we need to talk really more about obstructive sleep apnea, and thank you. That was really a brilliant presentation. Really enjoyed it.
Strong
thank
comment.
you, thank you.
Yeah, very good comments from Fazila. Prof. Koji, in Japan,
thank you very much. It is very important to diagnose and treat sleep apnea because as you presented, sleep apnea is very closely related to cardiovascular disease or cardiovascular death. My question is, you demonstrate that prevalence of sleep apnea in Malaysia is much more than that of Korea or Japan. But I think it depends on the population you screened. Do you know the population in that population screened in those studies? Is it true that the prevalence of Malaysia is much higher than Korea or Japan? I cannot understand the reason of that.
Thank you so much for the question and comment, professors. Well, I am not fully familiar with the source of the original source of the data, but that's true that all these really depends on the quality of the individual screening tests. For example, the way they diagnose obstructive sleep apnea, and also the population they study, and that's why normally we take this kind of data with a pinch of salt. But nonetheless, I think the importance here is that rather than looking at the comparison among different countries, I think that the fact that the message they want to convey is that is a highly prevalent problem, and close to 1 billion people in the world are being affected by this disease, and that's why I hope to raise awareness of this condition among the general public, and especially among the cardiologists as well, as the first comment is about.
Thanks, Ronald. Arintaya from Thailand, you have a comment?
Yes. Can I ask, because I have some experience doing a survey using sleep stop bank and Everett sleep scale, and the prevalence using these two questionnaires could be different. Have you experienced that as well?
First of all, at least in Singapore, I would say that we do not really rely on these questionnaires to diagnose obstructive sleep apnea, because if you know that the sensitivity and specificity are limited. Instead, we use it to select a group of patients who are a high probability of sleep apnea for an overnight sleep study. And that's the approach that we implement in Singapore. With regard to the question, I think that because these are two completely different questionnaires, first of all, they are not meant to diagnose, and secondly, because it's a simply different question. That's why the preference could be different based on the two different questionnaires.
Actually, our respiratory physician did say the stop bank seems to be better for Asians than the other questionnaires. Again, these are some of the comments I learned from our other physicians. Sidney, can I have one last question from you? Koji raised a comment about prevalence. In Australia, I think in our APSC countries, your country probably has the highest general BMI among patients. So do you refer a lot of your patients to the sleep specialists, and when do you do so?
So it's become kind of a pandemic. And so we're second to the US in terms of obesity, particularly childhood obesity. But my patients in the clinic, I asked them all to have a sleep. There's no selection. I asked them all to have a sleep study, and then they actually mostly refuse. So we have people sitting in my waiting room who are actually snoring, and we say, look, they've got sleep apnea. Even they haven't got a test proven one, but I can hear them stopping breathing in my room. And so yes, and I agree with you, Ronald. It's a great recommendation. I enjoyed the talk. Is that a lot of them don't tolerate CPAP, even if they come around to the sleep test and get prescribed a machine. Either too expensive, even where we are, it's not really funded, so they have to pay a couple of $1,000s for a machine, and often they don't use it.
Great comments. That was quite funny too. So we hope that Singapore doesn't get there. The only advantage is that patient may complain less. When they wake up, then the delayed TCU is right on time. So Prof. Koji, maybe we move on to the next.
Yes, let's move on to the next presentation. Next speaker is Dr. Joo Yeo from National University Heart Center, Singapore. His title is Pre-Participation Cardiac Screening for Young Athletes. Please.
Thank you so much, Professor Koji.
A very good afternoon. My name is Dr. Joo from the National University Heart Center, Singapore. Thank you to the APSC for your kind invitation to speak today. I will be presenting on pre-participation cardiac screening for young athletes and sharing with everyone the latest APSC consensus documents. So I will cover what exactly is pre-participation screening, as well as the current evidence for pre-participation screening in athletes. And finally, I will give everyone an overview on the APSC consensus recommendations for pre-participation screening in young athletes. So let's start off with the definition of an athlete. The American College of Cardiology and European Society of Cardiology use a qualitative definition of an athlete for someone who participates in regular competition where there is an emphasis on excellence and achievement. And these athletes typically train very systematically and exert themselves to the maximum limits. Likewise, there is also a quantitative definition which is less commonly used, whereby an athlete is defined as someone who exercises from anywhere from 4 to 10 hours a week or even more. It is important to look at athletes as individuals and individualize these recommendations to them. As you can see, athletes do come in all shapes and sizes, ethnicities, age, gender, so we really have to individualize our management. Next, let's go on to the rationale for pre-participation screening in athletes. Why do we need to screen athletes? Now, this picture shows Pheidippides, who is commonly known as the inspiration for the marathon race. He is actually a Greek messenger who passed away or had sudden cardiac death after delivering news that the war had been won by Greeks when he reached Athens from the town of Marathon. So in truth, he ran a lot more than 40 kilometers, but arguably he is the first documented sudden cardiac death ever. And so the reason why we screen athletes is to prevent sudden cardiac death in this population. When compared to non-athletes, athletes engaging in competitive sport actually have almost 3 times higher risk of sudden cardiac death. And this is based on the Italian data. But before you get alarmed by this figure, bear in mind that the actual incidence of sudden cardiac death is actually very low. Based on various population-based cohort studies, the true incidence of sudden cardiac death in athletes can range from anywhere from 1:50,000 to 1:15,000. So it is actually very rare. Nonetheless, pre-participation screening in athletes serves the following purposes: to identify cardiac diseases that are clinically silent that may be associated with sudden cardiac death. Thereafter, we have the potential to modify and reduce the risk of an athlete through individualized management. This can range from treatment of the condition, or in the most extreme situation, disqualification of the athlete from competitive sport. For other athletes, picking up of other cardiac diseases allows primary prevention of further development of the condition and improvement of heart health. And finally, it enables us to educate athletes on health risks, health-related behavior, and safe play in sport. Now, the evidence for pre-participation screening comes from this landmark paper from the Italians. It shows the benefits of a structured, mandatory pre-participation screening program. Let me draw your attention to the graph over here. The line in red refers to those athletes, competitive athletes in Italy, whereas the line in blue refers to the non-athletes. So in Italy, mandatory pre-participation screening started in 1982. And follow-up over the next few decades showed that there was almost a 90% reduction on the incidence of sudden cardiac death in the competitive athletes that have been screened. This is compared to an unchanged incidence of sudden cardiac death in non-athletes. So you can see that from here on, mandatory pre-participation screening actually saved a lot of lives of athletes, and the majority was due to disqualification of these athletes from competitive sport because of arrhythmogenic cardiomyopathy, which is relatively common in Italy. Now, the causes of sudden cardiac death in the young, which is less than 35 years old, can be divided into 3 main groups: structural heart abnormalities, electrical problems, as well as acquired problems. So the structural cardiac abnormalities, many of us may be familiar with hypertrophic cardiomyopathy, as well as arrhythmogenic cardiomyopathy. Electrical problems include channelopathies such as long QT syndrome and Brugada syndrome. As for acquired cardiac abnormalities, in this day and age of the COVID-19 pandemic, we should be aware of myocarditis, as well as some contact sports that have commercial causes, as well as performance-enhancing drugs. So with regards to the causes of death, let's look at how common each of them are. In the past, I think many of us, again, are familiar with hypertrophic cardiomyopathy, as well as arrhythmogenic cardiomyopathy being the commonest cause of sudden cardiac death in athletes. But depending on the region, and also over the last few years, there is increasing awareness of this condition called the sudden arrhythmic death syndrome. It is represented as the acronym SUD, sudden unexplained death, over here on the left side. So this denotes sudden death with an autopsy normal heart. And upon investigation of the families of these athletes with sudden death, more than 50% of the time, it is found that they would have an underlying channelopathy that is inherited in nature. So this kind of sudden arrhythmic death syndrome actually forms the majority of the causes of sudden cardiac death in athletes these days. Now let's go into the components of pre-participation screening. Typically, typically it involves a questionnaire, of the personal medical history as well as family history of the athlete to ascertain any inherited cause of sudden cardiac death. Next, there is a physical examination, and together, these are encompassed in these examples for pre-participation screening from the American Heart Association, European Society of Cardiology, International Olympic Committee, as well as FIFA. Some of the major sporting institutions also use the resting 12-lead ECG as part of the pre-participation screening, but this is controversial and we'll go into that shortly. So the ECG, from a clinical point of view, can help with diagnosis and risk stratification of conditions that can cause sudden cardiac death. For athletes with hypertrophic cardiomyopathy and arrhythmogenic cardiomyopathy, many of them can present with an abnormal ECG, even though they do not have any symptoms. Likewise, for athletes who have already known to have long QT syndrome or Brugada syndrome, the ECG can be used to stratify the risk of an athlete. For instance, in long QT syndrome, where the QT interval is more than 500 milliseconds, or if the athlete has a type 1 pattern Brugada ECG, these athletes are typically at much higher risk of sudden cardiac death. In addition, the ECG has been found to be more than 5 times more sensitive than history and more than 10 times more sensitive than physical examination. Of course, there are many other factors to take note rather than the clinical aspect when you use ECG for screening. That is, what is the prevalence of certain conditions that can be picked up by ECGs in your athletic population? How much resources can you devote for ECG screening? Are there skilled professionals present to interpret the ECG? And that will determine whether or not routine blanket-wide ECG screening is implemented or not in the screening program. Of course, over the last 10 years, with the development of new ECG criteria based on actual evidence in athletes, the latest version is the 2017 international recommendations that is cost-effective, reduces the amount of false positives, yet preserve its sensitivity in detecting diseases. Importantly, there is improved inter-observer agreement such that many different people agree on the abnormalities that are present in the athlete's ECG. However, an important point to note is that there is no Asian data yet. So taking all these into consideration, the Asia Pacific Society of Cardiology has developed a consensus recommendations for pre-participation screening in young athletes in the Asia Pacific area. We managed to gather many experts from the Asia Pacific region, and we've managed to publish this in the European Cardiology Review just late last year. So why did we embark on this project? Because Asia Pacific is home to more than 60% of the world's population, and yet there is very few recommendations for pre-participation screening for the athletic population. We have very few epidemiology data. Incidence of sudden cardiac death is not very clear, as well as reference limits for the Asian athletes. Importantly, the type of sport practiced within Asia is different from that of the Western world. Likewise, there's different prevalence of certain conditions such as Kawasaki disease, rheumatic heart disease, as well as Brugada syndrome. And there is also a wide variation in medical expertise and resources between countries in the Asia Pacific region. So to generate and develop these consensus recommendations, we did the following. We use a degrade system. We use a voting method to develop the consensus statements. We looked at the Commonwealth Games, Asian Games, Southeast Asian Games, as well as Paralympics to identify sports unique to the Asia Pacific region that enables inclusiveness and highlighting indigenous sport. And we decided to adapt the Mitchell classification of sport, first used by the American Heart Association. And just to jog your memory, this is the original Mitchell classification by the AHA and ACC. It involves a 3x3 categorization of sport based on their dynamic component, as well as the static component. So what we did was we used the same 3x3 classification and the same x-axis for the dynamic component and y-axis for the static component. But you can see the rectangles in red highlight Asia-specific sport, especially the martial arts, mixed MMA, Muay Thai, kickboxing, sepak takraw, dance sport, and we also included esports, which is a new sport that is being practiced more and more regularly nowadays. To simplify things further, we divided the 9 3x3 category into 3 major groups: low, moderate, and high cardiovascular intensity. So category 1A would be considered low intensity. Category 2A, 2B, as well as 1B would be moderate intensity. And all the sports in category 3, as well as category C, would be considered high cardiovascular intensity. However, we know that this is just a guide, and real-world practice of sport is fluid, and actual intensities are highly variable. So it is up to the practitioner to see if the sport does fit in this category or needs to be changed. So this is our summary flow sheet for the consensus recommendations. We focused on young competitive athletes below 35 years old who participate in moderate to high intensity sport. So that is based on the 3x3 classification, anything other than category 1A. We have 5 main statements, 4 of which are shown over here. So I will go into each statement in detail, but statements 1 and 2 pertain to the recommendation for pre-participation screening using history and physical examination, as well as the ECG with some caveats. Statement 3 pertains to referral to a qualified healthcare professional if any abnormal findings are detected. Statement 4 deals with the low intensity sports and the need for cardiovascular screening is not necessary. And statement 5, which is not shown here, refers to athletes with pre-existing cardiovascular conditions. So let's quickly go into these statements. So our first statement recommends that young competitive athletes participating in moderate to high intensity sport based on the classification shown earlier should undergo a standardized history and physical examination as part of pre-participation screening. And a suggested checklist for the history and physical examination is the AHA cardiovascular screening checklist or equivalent. The second statement pertains to the use of ECG. So the ECG should be used provided that all of the following are fulfilled. Number 1, the screening institution has the capacity for mass ECG screening. Number 2, the ECG can be performed to an acceptable standard. And number 3, the ECG should be interpreted by a trained healthcare professional with reference to prevailing standards. In this case, the 2017 International Recommendations for ECG Interpretation in Athletes. Our third statement refers to the referral of the athlete to a qualified and relevant healthcare professional or specialist. In this case, this is typically a sports medicine physician or a cardiologist who is trained in sports-related conditions. So referral should be done or made in the presence of any of the following. If any point in the history is abnormal, any point in the physical examination is abnormal, or if the ECG is abnormal based on the international recommendations. That is, if there is a red category for abnormal ECG findings, or 2 or more borderline findings on the amber category. Our fourth statement refers to participation in low cardiovascular intensity sport, as well as master athletes. We felt that routine pre-participation screening for this population is generally not necessary. Why is this so? Firstly, the risk level for participating in low intensity sport is low. Number 2, there is lack of supporting evidence for routine screening in this population. Moreover, we acknowledge that there is a lot of resource challenges within the Asia Pacific countries, and the emphasis should be on optimizing healthcare resources, especially in the midst of a COVID pandemic. And we should try and encourage sport in low-risk situations by minimizing barriers. So pre-participation screening before for low-intensity individuals would provide another barrier to participation in sport. Our fifth statement refers to athletes with pre-existing cardiovascular disease. There is already a wealth of evidence present in the literature, and that would not be appropriate in our consensus statement. So therefore, for athletes with cardiomyopathies, myocarditis, pericarditis, pre-existing coronary artery disease, arrhythmias, channelopathies, as well as COVID-19, there are recommendations already available, and readers are directed to these recommendations. So our consensus statement literally touches the tip of the iceberg when it comes to sports cardiology, but we hope that this actually increases awareness in the Asia-Pacific region. We know that these statements are mostly consensus-based and not absolute mandates, but it provides some sort of guidance with room for individualized care. We acknowledge that implementation of ECG screening, there's no evidence to show that it improves outcomes, such as reduces mortality in athletes. So these are all knowledge gaps that require further evidence, especially in Asian athletes. We need to know the epidemiology of sudden cardiac death, as well as the physiological limits of cardiac remodeling, so that we know how to identify athletes who require further evaluation. With that, I would like to acknowledge the wonderful colleagues from the APSC writing group, headed by our APSC past president, Associate Professor Jack Tan, and also the educational grant from the Lee Foundation that made the writing of these consensus recommendations possible. With that, I thank you very much for your time.
Thanks, Joo. Thanks and congratulations for being the co-first author for this initiative. I couldn't have done it without you. So I'd like to welcome Dr. Arintaya. We put Muay Thai as one of the most tough sports across Asia, I think. Any comments from you about this paper, Arintaya?
Yeah, thank you very much for your very informative presentation, and congratulations for the consensus document. And thank you once again for putting the Muay Thai for the top sport. And as you mentioned that the most common cause of the sudden cardiac death in the young athletes is sudden unexplained death, which the physical examination might not be able to find any abnormality. Just wondering if we could use like artificial intelligence to include information from history, family history or symptoms, as well as ECG, because you said that the most difficult thing about the ECG could be the interpretation of the ECG, which needs the expert. Is it possible to combine that history and ECG using artificial intelligence to classify the risk of the patients rather than physical examination? Because I think mass physical examination is possible visibility will be lower than mass ECG test.
Yes, thank you very much for the very insightful question. Well, with regards to the use of AI, I think nothing is impossible. I think we have another colleague of ours, Professor Khung Keong Yeo, who is very well versed in this aspect. So we can get his insight on that. But with regards to all these questionnaires, I think the key is for the provider to actually ask the patient carefully. This is because the athlete sometimes has very subtle symptoms that they might actually play down or ignore. And this might be clues to some more sinister underlying cardiomyopathy or any potential fatal condition. So a very detailed history of family history of sudden cardiac death, even in distant relatives, that's one, as well as personal history of any, for example, unexplained dizziness, chest pain, palpitations, all these, I think as the provider needs to actually take a lot of emphasis once the athlete reports something very subtle. I think that's the main point to be aware of.
Thanks, Tiju, but great question. I would now like to ask then Khung Keong Yeo, because KK is also involved not just in AI, but in our Singapore SAF screening. And we say maybe the SAF guys don't even need an ECG. So based on this, what are your thoughts on this paper, KK?
Thanks very much, Jack and Tiju, for this wonderful piece of work. So as it turns out, I do have questions, and it was only because a lay person read the paper and gave me a call and said, well, my kid is 11 years old. So what is your definition of a young athlete? So he plays soccer, so he's 11 years old, and they are saying, should we do an ECG for him? So I gave it some thought, and I ended up with more questions. So one to Tiju is how young is young? And I know within the paper it say 30 years old. Then the second question is that how frequently should we repeat that? So say the first ECG is normal, and then after that he goes to high school and he's now 15 and he's about to start joining the school team. Should he have another ECG? So just those two questions. Just before that, to Arintaya's question on AI, I think it's possible, but a lot will depend on the quality of data that we get, the ECG. And I think for some of our cohorts, it probably is something we should explore. So thank you for that suggestion. Back to you, Tiju. Thank you.
Thank you, Prof. Yeo, for the very insightful questions. So with regards to the age limit, actually, as long as the athlete is competitive, so there is a scheme of structured, systematic training to limits, then he or she can undergo ECG as a screening. The only downside of this is that what is the reference? So we have reference limits for pediatric or adolescent athletes in the Western world. And we also know that for pediatric athletes, they do have pediatric T-wave inversion changes that are actually physiological. So, I think having some, testing will at least, in a competitive adolescent athlete, will at least give us some sort of a baseline for comparison and give us an opportunity to implement the history and physical examination questionnaire as part of the whole pre-participation screening. So that there is no, to me, there is no lower limit. As long as the athlete is competitive, he or she should get a PPS done and then get interpreted by a trained professional to see whether further evaluation is to be done. This is particularly important if there is any family history.
Thank you. Thank you.
Of Koji, maybe.
Okay.
Yeah.
Okay. Then thank you, Dr. Joo. Let's move on to the next presentation. Next speaker is Dr. KK Yeo. He is a chair of SAB of APSC and the National Heart Center, Singapore. His title is Kawasaki's disease. Dr. KK, please.
Thanks very much. Thank you very much, Professor Maemura. So it's my pleasure and honor to present on behalf of the work group the draft consensus statements on the management of adult complications of Kawasaki's disease. This is in collaboration with the Japanese Circulation Society. We are almost done with the final document, but this is for now the draft. Some conflicts of interest. So the background to this paper is that we started discussing back in 2017 and 2018 as to a document that might help guide us with some rather Asia-specific illnesses. And the one that came to mind was Kawasaki's disease. We followed up with an in-person meeting in Paris at the sidelines of the ESC meeting in 2019. But in the following year, COVID came along and everything was relegated to email and Zoom meetings. But we're happy to report that, with the advent of the JCS 2020 guidelines, we were able to bring this document to where it is currently. Within the meeting here today, there are, already members present. Professor Maemura himself and Dr. Sidney Lo are also members of this committee. We have a lot of representatives from Japan highlighting their role, instrumental role in guiding us in this particular formulation. So Kawasaki's disease is an acute self-limited vasculitis of unknown origin that occurs in young children. Approximately 25% of untreated Kawasaki's disease and 5% of those treated with IVIG go on to develop coronary artery aneurysms. And these aneurysms from Kawasaki's disease account for about 5% of ACS in adults less than 40 years of age. I think data from some other, sorry, this set of data came from the Los Angeles area in the United States. But there are data from other Asian countries that put a number at approximately 9%. This is the aforementioned JCS, JSCS 2020 guidelines. And we also highlight the fact that you can see here that the rates of Kawasaki's disease, both the complete and incomplete cases, have risen over the last couple of decades. I should also mention that with the introduction of aspirin and IVIG, the mortality rates have also come down dramatically, highlighting the importance of medical science in treatment of such conditions. Now, other than the JCS guidelines, we also took a lot of reference from the AHA scientific statement in 2017, and also a publication from the British Cardiovascular Society published in 2020. The AHA guidelines, or rather scientific statement, I think what was important is the establishment or the recommendation that we use the Z-score to determine the size of a coronary artery aneurysm. And the Z-score is essentially a standardization to the body surface area of the size of the aneurysm. Now, briefly, if there is no coronary artery aneurysm, the Z-score is always less than 2. If it is dilatation only, then 2 to 2.5. A small aneurysm, 2.5 to 5. A medium-sized aneurysm, 5 to 10, with an absolute dimension of less than 8 millimeters. And for large or giant aneurysms, more than or equal to 10, and absolute dimensions of more than or equal to 8 millimeters. The problem is that the Z-score, because it's a formula with reference to the body surface area, can have different formulae. And this is just a sample of 7 different formulas through the years, including, amazingly, one from Singapore, where we have different formulas. And you can see here, even the method of calculating BSA is different. Furthermore, the age range for these formulae range from 2 months to 8 years, which means that in adults, we do have a problem. What formula do we use? And can these ranges, which were based on echocardiography, be used in adults? As you know, in adults, the measurement of coronary artery sizes on echo is challenging. Be that as it may, here are the statements that we agreed upon. Now, this first statement is the one statement that I think needs a bit of work. We have recommended that coronary artery lesions should be quantitatively assessed for intraluminal dimensions and classified into small, medium, and giant aneurysms. This particular definition is based on the 2013 JCS guidelines, and essentially a small aneurysm or dilatation is when it is less than 1.5 times that of an adjacent segment. For the medium aneurysm, 1.5 to 4 times, and for a giant aneurysm, more than or equals to 8 millimeters. Now, because of the AHA and the JCS guidelines, and in the absence of clarity about the use of the Z-score in adults, we also would like to provide an alternative, and this is recommended by Professor Fukuzawa, the lead author for the JCS guidelines, that until there's clarity, we should provide an alternative definition, which we will put in the actual written document. The second statement is that coronary artery lesions should be risk stratified according to their initial Z-score during the acute phase of the illness, and their maximal Z-score measured at least 1 month after the acute phase, and selective adjunctive tests may include coronary angiography. I will read out the entire table. Suffice to say that for patients with the highest risk level, they would have coronary artery stenosis as well, and 5A is without ischemic findings, and 5B is with ischemic findings. And the reason for this risk stratification is to inform subsequent management and necessary follow-up. And this is exactly what I mean here. So statement number 3, consider interval investigations and long-term follow-up as shown here. What is important is that in the absence of dilatation, or in the absence of, or in the presence of only transient dilatation, then long-term follow-up is not necessary, and neither is assessment for inducible ischemia. For the rest, you can see that follow-up as well as ischemia testing may range anything from annual to every 3 to 5 years. Now, number 4, for Kawasaki's disease without coronary involvement or those with only transient coronary artery dilatation, long-term follow-up is not required. But this should be clarified against aneurysms that have regressed. For regressed aneurysms, it is reasonable to follow up Kawasaki's disease patients even in the long term because of potential coronary events based on the functional and structural abnormalities in the coronary vessel wall. The next 3 statements refer to the following. First, number 5, consider stress echo as a minimally invasive method of follow-up. Other methods, of course, can be used, nuclear stress testing, stress MRI, for example. Coronary angiograms remain a gold standard, not surprisingly. And number 7, low-dose aspirin should be continued for all patients with remaining aneurysmal coronary artery lesions of any diameter. DAPT, that is aspirin or a P2Y12 inhibitor, may be considered in patients with remaining medium or giant aneurysms. Warfarin, in combination with low-dose aspirin, should be administered to patients with remaining giant aneurysms, past history of MI or known thrombosis in the coronary artery aneurysm, with a target INR of between 2 to 3. We also made a point within the description of within the text that low molecular weight heparins may be a reasonable alternative for patients who are unable to achieve a stable level of anticoagulation of warfarin. And we also took note that there are limited data on the DOACs in these patients. Triple therapy with aspirin, an additional antiplatelet agent, and warfarin may be considered in patients with high risk of thrombosis, for example, those with giant aneurysms and recent history of coronary artery thrombosis or stent implantation. Number 11, DOACs may be considered as an alternative drug to replace warfarin in the recommendations above. However, it should be noted that data regarding its use in this disease is limited. But we felt that given the body of evidence in other areas of anticoagulation and thrombosis, such as atrial fibrillation, deep vein thrombosis, and pulmonary embolism, that the use of DOACs in place of warfarin may be considered after appropriate discussion with patients. Number 12, empirical statin therapy should be considered in patients with remaining aneurysms of any size for their non-lipid lowering pleiotropic effects. And number 13, not surprisingly, in acute MI, primary PCI should be considered as the primary reperfusion therapy. Number 14, for patients with high thrombus burden within the aneurysm, intracoronary thrombolysis and or intravenous antiplatelet agents, for example, abscesimab, can be considered. We also felt that in this particular area, because of the presence of aneurysms which may have thrombus or layering of plaque present, the intravascular imaging of some sort, whether it's IVUS or OCT, may be considered to assess the true luminal dimensions to guide PCI. Within the Japanese guidelines and a lot of case reports, the use of rotational atherectomy or orbital atherectomy or other adjunctive therapies such as shockwave may be required for calcific stenotic lesions. And whilst plain old balloon angioplasty may be effective for localized stenotic lesions without calcification, the global experience is that after a few years from the onset of Kawasaki's disease, because of calcification, POBA alone is unlikely to be successful. Number 18, the primary indications for bypass as a means of revascularization should be considered in accordance with established PCI and CAD guidelines. Now, I've gone through all these statements rather rapidly. The Z-score controversy remains troublesome, but I think there remains, other than the Z-score, other gaps in our knowledge. For example, while there are some case reports out there, the role of new antiplatelet agents such as prasugrel and ticagrelor have not been systematically studied in this condition, and neither has the role of DOACs such as dabigatran, rivaroxaban, apixaban, etc., been established for this combination. The combination of these drugs, antiplatelet agents, DOACs, etc., also have not been established. In terms of interventional technique, the use of drug-eluting balloons or drug-coated balloons, self-expanding stents, covered stents, or bioresorbable stents have certainly not been explored systematically. We are also unsure of the target for LDL lowering. We can only take guidance from established literature for atherosclerotic disease and impute that the current guidelines will also apply to Kawasaki's disease, coronary artery late manifestations. And of course, given new drugs such as the monoclonal antibodies, I can pronounce the canakinumab name, colchicine, the role of these drugs, early, late, is also unclear. And of course, with these drugs, it is also unclear what is the optimal duration of therapy, whether they should be given in childhood or in adulthood. So in conclusion, we first acknowledge in these statements that there are limited data in terms of the management of late coronary complications of Kawasaki's disease. But be that as it may, it was important for this region to provide some guidance, and the statements that we felt were important is that we would recommend antiplatelet agents for small to moderate aneurysms, and we would add an anticoagulant for large or giant aneurysms. According to risk stratification, routine ischemia testing may be necessary. PCI remains complex, and one will have to manage the underlying thrombotic and calcific thrombotic presence and calcific stenosis. And with that, treatment strategy should be individualized. I'd like to thank the other members of the writing committee, and especially our friends from the Japanese Circulation Society, especially Professors Fukuzawa and Mitani for their contributions to this paper. Hopefully we will have it completed in the next month or two. Thank you.
Thank you, KK. I really appreciate you for wrapping up various opinions from Asian countries. And it is very precious for us, APSC, to publish this Kawasaki statement from Asia. I thank you very much.
Thank you.
We also like to thank Prof. Koji for being one of the lead drivers for this as well. We'll have Sidney make a comment. You are one of the group. What are your comments for this? And maybe I can ask you specifically, although there's a data gap, what is your opinion on covered stents as well as DCB use? Is it contraindicated?
So thanks, Jack. Thank you very much. It was my honor to be involved. I learned a lot from the Japanese doctors who are experts in the field. And KK's done a wonderful job organizing this statement. And number one, I think that it's a learning process. And I think we talked about this during the Kawasaki session. I don't think I have a particular preference. I think it's complicated depending what kind of anatomy you have. And we talked about, my concern is mostly with drug-coated balloons, because drug-coated balloons deliver quite a high toxic, what I call vascular toxic dose to the vessel. The dose delivered is much higher at the surface than the drug-eluting stents, particularly paclitaxel, with a very narrow therapeutic index. And as you probably know, DEBs are very commonplace in Asia for small vessels. And sometimes when they come back, they look bigger. And we learned from many years ago in India, when they have quality issues with stents, they actually have too much paclitaxel and come back with giant, enormous aneurysms in the coronary artery. So having aneurysms to begin with and treating them with a drug-coated balloon may actually cause more aneurysms, and it's a concern. So, but we don't know. There's not evidence-based. My comment is that we are still in the early phase of learning how to deal with adults. So I think the population has been in Japan, Taiwan, etc., and Korea, rather than in Australia. But for the adult interventional cardiologists, we see angiograms, and we often don't label it because we see the luminogram. We don't even know how big the arteries are. We're surprised on CT scans, maybe the aneurysm are actually quite large. So the internal lumen diameter is problematic. So maybe KK, and also known Kawasaki's young patients transiting to adults are often lost. It's like adult congenital heart disease. They don't want to see doctors anymore. They feel well. So KK, what's happening in Singapore, and what's a recommendation about losing those known Kawasaki's patients from young age to adulthood, as well as how to move forward with the adult cardiologists?
Thanks very much for that, Sidney. So as it turns out, within our screening program for soldiers, young men can volunteer information regarding whether they have had Kawasaki's disease before. I would say that the numbers of patients who on cardiac MRI pick up, coronary artery aneurysms is very small. Based on that, I think, I don't want to misquote the data, but I would say that really vanishingly small. So as it is, we're working with, to try to write that protocol up and to share the data from our, formal screening program. And I think that would help inform practice. Of course, Singapore is privileged. We do get access to IVIG very early on, and it might be that that has shielded our folks from the late complications. Thank you.
Thanks, KK. Dr. Fazila, in Bangladesh, do you see a lot of Kawasaki's and your comments for this paper?
Thank you. That was a great presentation, learned such a lot. And actually, I don't really have much experience with Kawasaki's, but it's a fascinating topic. And I just wanted to learn, you said in your presentation that with the aneurysms which tend to regress, we don't really need to do a lifelong follow-up and all. So my question is, what's the incidence of regression? And another thing is about statins. So if I want to treat my patient with statins, what kind of dose would you recommend? Very high doses or not?
Thanks, Fazila. Actually, I think it's good to clarify that point, and maybe I didn't say it well enough. So there's a distinction between transient dilatation, in which the aneurysm, or the dilatation to be more specific, normalizes within a month, versus regression where the aneurysm has been present beyond that period of time, but then gets smaller. For regressed aneurysms, they should be treated in accordance with the risk level which we had provided. So for regressed aneurysms, they still require lifelong monitoring according to these consensus documents. To your second question about lipid lowering with statins, we don't know what the optimal level is. If I were to make a suggestion, I would say that we should target as aggressively as standard CAD, and I'll put them in the high risk category or very high risk category, if only because of the underlying possibility of stenosis and thrombosis, and also to leverage off the pleiotropic effects of statins. But I acknowledge that we have a knowledge gap in this area. Thank you.
And the last question, sorry. I mean, to all of you, have you any experience with covered stents? Because theoretically it makes sense, right? You cover it with a covered stent. I mean, do you have any experience with that? Treating Kawasaki's giant aneurysms with a covered stent?
Not myself personally, Jack. Sidney?
Sidney first. I think Sidney is the most experienced here.
No, we've medically treated a few, and I think for the aneurysm, sometimes we've stented the neck either in. That's the most prone area for stenosis, neck going in and neck coming out. But the aneurysm itself is a bit problematic exclusion. I personally think that covered stents have a higher thrombotic risk and poorer result long term. And so, but there's no data to guide that. And I think we've done very few with covered stents, maybe one.
Yeah, so very difficult to comment, Fazila. Great question. It's probably going to be case by case. We don't know whether they are prone to rupture in the first place, but definitely prone to thrombosis, and whether a covered stent does help them, I'm not sure as well. Personally, no experience. And Prof. Koji?
Okay, maybe we need to close this session. Today, for Asian document presented, although many guideline or statement published from Western countries, but prevalence of some disease such as Kawasaki are different from Western country and Asia, and way of diagnosis or treatment is also different from Western country and Asian countries. So it is very important for APSC to publish guideline or statement in the near future repeatedly. Thank you very much. I thank all speakers and discussants. Thank you very much. I'd like to close this session.
Thank you, everyone.
Thank you.
Appreciate
Thank
your
you,
time.
everyone. See you
Great
next
job.
time.
Thank you.
Bye.